Great. Well, happy to have you all here. I'm gonna go ahead and kind of get started with a little introduction, and then we're gonna hand it over for our wonderful presentation today. So I'm Kate Comtois. I'm a psychologist in the Department of Psychiatry and Behavioral Sciences here at the University of Washington, and I'm the director of the Center for Suicide Prevention and Recovery, or usually we call it CSPAR. So if you are new here, our center is a center of faculty and staff dedicated to promoting the recovery of individuals experiencing suicidal thoughts and behaviors, and to the kind of effectiveness and the resilience of the clinicians and the family who take care of them. This is our monthly spotlight presentation, which is the third Thursday at 9 Pacific or noon Eastern, or welcome from whatever time zone you're in. And they are recorded for the purpose of being able to make them available for people for whom this is not a good time. So uh, Macy will put into the chat the link to where you can find previous presentations if you're interested. We also are hoping that you all will sign up to hear about the things that we're doing at CSPAR and these talks in particular. And Macy will put a link to be on our mailing list, and then you'll hear about the future talks as well as the different trainings that we provide. We got a little off our game from being every month as we used to, by the big distraction of us receiving a NIMH P50 grant, what we call our Suicide Care Research Center, focused on adolescents and young adults in the primary care and other outpatient medical setting environment. That also has a spotlight talk, by the way. You're welcome to attend that as well. Macy will put that link in there as well. And we now will be kind of back on the regular with our third Thursday spotlight talks for CSPAR. Today, I am very happy to introduce our one of our core CSPAR faculty, Larry Pruit, who helped create the center with us, and his colleagues from the Department of Defense, to present their overview of the evidence for evidence-based suicide prevention. As you can see, Larry is a critical force in our Pacific Northwest region for the VA and many programs across the region, reaching out beyond the VA for suicide prevention. And Dr. Smolenski and Evatt are both from the Psychological Health Center of Excellence, which is a core office for epidemiology and research across the Department of Defense through the Defense Health Agency. And Larry, I'll hand it over to you and give you the time to kick it off.
Great. Thanks so much, Kate. Really appreciate you having us here, and thanks everybody for joining. I see a few familiar faces in the roster, so that's great. Again, I'm Larry Pruit, joined by Derek Smolenski and Dan Evatt. And as we get started today, I want to start with just a couple of disclaimers. One, just acknowledging that this is a difficult topic oftentimes to discuss, especially in large forums like this. And I want to acknowledge that and recognize that, if you're struggling, or if you have any issues that come up, please take care of yourself, and we can certainly be available to assist with that if needed. Our intention as we go through is to not dismiss the suffering or the loss of life due to suicide, but oftentimes these talks become very serious and kind of heavy. And one of the things we're going to do in this talk is try to bring a little silliness and a little humor into this, to really draw a juxtaposition between where things are at and where they could be. That is not to take anything away from the ongoing and tireless efforts of our colleagues around the US and worldwide to address suicide from both clinical, public health, and academic arms. So we're there, we do that work on a daily basis. And I think from that, we can see, like, we can look at this through a different lens. Um, as a representative of the federal government, all three of us also have to say that the opinions we share today are our own, and they are not the official policy of the U.S. Department of Veterans Affairs, the U.S. Department of Defense, or the U.S. government overall. And it's worth acknowledging that we're all coming from the DoD and veteran community, so we're going to have that lens on things a little bit as well. Although I think what we talk about today is going to be applicable regardless of the populations that you work with. Okay, so that brings us to kind of the central theme of our talk today, which is that suicide prevention and intervention has a big foot problem. And so you might be thinking, what do you mean by that? And just to kind of set the stage a little bit, you might look at this list of statements and think, oh, those apply just to, Bigfoot. And if you're not from the Pacific Northwest, Bigfoot is sort of this mythological creature that no one's been able to really find, but lots and lots and lots of people believe exists. You can't go anywhere without finding stickers and bumper stickers and collectibles and all these things with Bigfoot on them, like it's a real thing, right? Okay, so you might read these statements and think, oh, these all apply to Bigfoot sightings. And I would challenge you to actually do the opposite. Let's stick suicide prevention into those statements. And does it change anything? I would argue that a lot of the things we would say about Bigfoot, we could also say about suicide prevention intervention, right? And what I mean by this is that oftentimes when we are trying to tackle elusive problems and we're coming from it from the side of having good intentions, we tend to overcommit to strategies that are face valid, but don't necessarily have a lot of good backing evidence behind them. So when we're in kind of this perfect mix of, an elusive problem and good intentions, we tend to do things like combine interventions that seem like they'd work well together. We tend to change our standards for what an acceptable level of evidence is because we want these things to change. We want to be able to reduce suicide. We tend to adapt practices from similar targets without really good support for doing so. And then we overcommit the strategies that have been sort of part of the culture for a long, long time, again, sort of regardless of what the evidentiary support says about them. So said another way, you can kind of walk through the thought exercise here, moving from box 1 to box 4. But the takeaway from this is we've taken a kind of kitchen sink approach to suicide prevention. And over the last 2.5 decades have instituted numerous programs at very large scales. And if we had somehow included an effective strategy in that, shouldn't it have evidenced itself by some reduction in suicide rates in the populations that we've looked at, including the VA, the DoD, SAMHSA, the CDC. And across all of those very large public health organizations, we've only seen rates increase. And so the question becomes, is it working? Or why isn't it working? We may not know how, but if something was there, we should be able to say that it is or isn't. And so if we start looking at the key components, the big sort of interventions that have been applied for suicide prevention, you start sort of seeing a pattern. And this pattern has really been sort of, I think, put pretty succinctly in the most recent clinical practice guidelines from the DoD and VA, which states that to date, there is really a lack of high quality RCTs with suicide mortality as the primary outcome. We're going to talk more about that in a second. As a result, the recommendations for suicide prevention interventions are based on the best available evidence, and the strength of the recommendations reflect the limits of the evidence base. And if you look through that CPG, what you find is that there's not a lot of strong recommendations for any of these strategies. Not that these aren't good, earnest, potentially beneficial programs, but that we don't have an evidentiary base to say, hey, this is the thing that's going to reduce suicide. And as a result, as we continue to monitor suicide rates across the veteran and military communities, what we find is that rates have continued to increase and in fact are separating in a problematic direction where our military and veteran populations are at continued higher risk than the general population. Now, I do want to caveat that when it comes to lethal means safety, there is some good evidence to show that this does work when it's applied at the population level, like switching from coal burning gas to natural gas in cooking stoves, preventing asphyxiation by carbon monoxide, or installing bridge nets at suicide hotspots around the country, or outlawing certain pesticide chemicals that are toxic to humans. And one of the most notable things about these sort of population level changes is that they do show a reduction in suicide risk without a corresponding increase in other methods of suicide, which is, I think, especially important. So the question in my mind then becomes, why are we continuing to approach suicide prevention research by targeting suicide as the key outcome? And to switch analogies from Bigfoot to heart disease, let me talk through that a little bit. In my mind, this is sort of like targeting heart attacks rather than targeting heart disease, right? If our goal is to reduce myocardial infarctions, we can do one of two things, or ideally both. But we can target better bypass surgeries, right? And really refining our processes for doing that. Or we can take the lens of how do we improve diet, exercise? How do we better understand the genetic makeup that puts somebody at risk? Those sorts of things. It focuses on the pathogenic process that leads to that outcome rather than solely looking at the outcome itself. And I think we need to do that with suicide prevention as well. Rather than looking only at suicide as the outcome, although we certainly need that there, we also need to look at what are the contributing conditions and factors that lead somebody to be at risk. What are the biological factors, the psychosocial factors, the genetic factors that contribute to that? Maybe it's depression, maybe it's anxiety, maybe it's a marker for a psychotic disorder. But understanding those process pieces can then get us to better understanding of the outcome of interest. And so what if the trick here is really to have a scaled approach where we start on a very broad upstream level where our interventions are designed really for improved public health around those factors that contribute to suicide. And we move towards an intermediate or effective disease management model. Finally, for the few folks that remain at really high risk, that's where we apply sort of the crisis intervention model to divert those individuals from that outcome, knowing that those other strategies that have been applied more broadly earlier on in the process have reduced the risk for those folks, for most of the folks that are in that funnel. So as we go through and talk today, we're each going to tackle a different area, and our objectives are really to cover some of the issues that contribute to this lack of evidence for suicide prevention interventions. So I'm going to talk about proxy outcomes here in a second. I'm then going to turn it over to Dr. Smolenski to talk about how we actually evaluate the evidence, and Dr. Evatt will wrap up with some recommendations for the future. So kind of my personal area of concern here are the use of proxy outcomes in suicide prevention research, sort of like this footprint you see in the background of the image here, serving as evidence that some sort of mythological creature might exist out there that we haven't found up to this point, right? We use a lot of proxy outcomes in suicide prevention research. Suicide attempts, non-death related suicide related behavior, non-suicidal self-injury that can happen for various reasons, risk-taking behaviors, crisis line calls or service utilizations, In the VA, something called a suicide behavior and overdose report, visits to an emergency room, and that list can go on and on and on, right? There's lots of things we say, this outcome is going to be what we use because measuring suicide is too few and far between, doesn't occur often enough. We'd have to have this huge study that couldn't be afforded or conducted in a reasonable period of time, those sorts of things. And that becomes where we run into these problems. As an example, okay, we originally did this presentation down in the Portland, Oregon area, so I found a map of that region, which you see here. The thing to note is that people select proxy outcomes in their research for a lot of different reasons, a lot of which are valid. They're more frequent, they're easier to measure, they're lower cost, and you can get better statistical power. But the sort of allegory here is what you see on the image behind you, which is those proxy outcomes are like all these markers on the map. There might be different things we could use. Maybe it's the call of the Bigfoot that you see with the little sound markers, or a sighting, or a footprint, right? And there's lots of those that have occurred, and lots of folks can point to experiences with those things. None of those have translated to an actual discovery of Bigfoot, though, right? And that's the concern, is that if we take these lesser forms of evidence, we may miss the true thing that we're trying to study. And so we don't want to settle for proxy outcomes when we're trying to get at something really important. And that's because a close enough approach can lead to a couple of different problems. The first being high false positive case identifications, right? That there's a signal of a high-risk situation, but that it represents somebody who's not necessarily going to die or be truly at risk for suicide. Even more problematic, high rates of false negative case identifications, right? Where we're signaled that somebody is not at risk, but then they do go on to experience a suicide-related event or behavior that could ultimately cost them their life. We don't want to miss those cases, okay? So what you end up with is a lot of face-valid intervention strategies that are, at the end of the day, ineffective at changing the rate of the occurrence of the behavior. And that can kind of become sort of ingrained in the mainstream and carry a lot of weight with it unnecessarily. So let me give you an example of that. Again, looking at one of the best Bigfoot sighting examples we have, right? And if we're saying, okay, this is evidence of Bigfoot, we don't have, the actual thing, but we have this photo, and so maybe we're just going to try and define this issue as, any bipedal fur-covered primate in the Pacific Northwest. And if we use that criteria, that really captured this and differentiates it from other things and allows us to say that this is a true phenomenon, right? But at the end of the day, you're left with the question of, couldn't this just be a guy in a furry costume and still meet all of those criteria? And the answer to that is yes, it could. And in fact, it was, right? But if we use those proxy criteria, what we end up with is coming to a conclusion that something is true or valid and propagating the belief in that then gets picked up by the mainstream. And this is an example of how that happens. You now have an intervention, right? Somebody put up a sign, and the sign explicitly says, this has been posted for your safety. So there's an intervention that has occurred based off of problematic and incomplete evidence that doesn't really capture the problem. And so I'm going to go back to the CPG for just a minute and really offer kudos to that work group, because they said, hey, before we can offer a recommendation for anything having a strong enough evidence base to be included as a recommendation, we're going to require that there is a valid RCT completed within that population, looking at that specific intervention and being able to rule out other causal factors, and using suicide prevention or suicide outcomes as the outcome of interest. And so to talk more about sort of that level of evidence, because it's a pretty high bar, I'm going to turn it over to Dr. Smolenski.
Greetings. Apologies for not being able to join with better technology, but we have limitations on the DoD network today, so I'm joining you telephonically. I'm going to talk a little bit about some of the design and statistical aspects of evidence for suicide prevention. Hopefully not get too deep into the weeds and just leave you with the highlights. So the biggest things that we're looking at for evidence, ideally we want evidence that is free from bias, that is consistent, so that we're seeing multiple signs pointing in the same direction, that it's precise, so that when we look at the evidence and we're trying to decide whether something is worth the inputs, that we're pretty confident about what the direction and the size of the effect is going to be. And we want to see directness, so that the treatment is really the treatment and evidence is the treatment we're going to use, and that the outcome, and this is important for suicide prevention, that the outcome that we're targeting is the outcome that's actually under study. Next slide, please. This is a causal diagram. So we'll say this is a very generic one for what we think is going on when we're looking at a particular treatment and its effect on suicide, and in this case, specifically suicide mortality. We have to think about things called confounds, so factors that are prognostic for both treatment and suicide. So think prior suicide attempts. Individuals with that may be more likely to engage or not engage in a particular treatment, and they have an elevated risk of suicide relative to people without a prior suicide attempt. So you would want to have a way to account for that. There's also alternate causes that are not associated with treatment affiliation, and so they're not as big a concern from a validity standpoint. Next slide, please. With the causal inference that we're trying to get at, we need exchangeability and positivity. So with exchangeability, our treatment groups look similar. So those measured confounds and those unmeasured confounds are balanced between people who do and do not receive the treatment. And positivity, people that are in our study and that are being compared, and this is most important, I think, if you're looking at observational studies, but everyone had a chance of getting the treatment. If you compare people who had the treatment to people who didn't and never were going to, then you have a risk of bias. And then consistency is a little bit more esoteric, and we'll skip over that for now. Next, please. The benefit with an RCT is as you randomize larger numbers of people, you create that balance. So you are establishing the exchangeability between your study groups. And so the effect of those confounds on treatment, that gets canceled out, and that leaves a valid causal inference for the effect of the treatment on the outcome of interest. If you're in an observational study, you don't have the benefit of the randomization, so you have to identify all of the relevant confounds, measure and account for them either in your design, analysis, or both. And that's really one of the big sticking points that we have for non-randomized studies when evaluating the level of evidence. Next slide, please. So what do we need to see in terms of events? And in suicide prevention, with a discrete event like death by suicide or suicide attempt, we're looking at a count outcome. And that's going to be the effect size that we can detect, and the size of our study will be driven by the number of events we expect to see in our treatment groups. And so as the percent reduction of risk gets smaller, so the effect size of interest gets smaller, we're going to need to see more deaths in the referent group. The more deaths you need to see, the larger the sample you're going to be, and that's also driven as a function of what the risk is in your target population. Next slide, please. I think this is an important consideration, and the take-home message from this is our traditional methods of designing a study where you're considering the power and the level, the alpha and beta. So your the type 1 and type 2 error probabilities that you're going to set. If you design a study and look at your sample size based just off those criteria, you have risk of getting a really broad confidence interval. So the blue one at the top there. If you consider other factors related to precision, so not just that we are seeing an effect size, but that we have a precise estimate. So we know, we're very confident that we're seeing something of a reliable magnitude. That's going to narrow the interval, but that means you're going to have to increase your sample size. And as you can see over on the right-hand side, we're talking for a reasonable reduction, say 30%, you're needing several hundred deaths in your referent group to come away with a statistically significant finding that's also precise. So note to the consumers of the literature, when you see trials that are reporting a significant effect for treatment and they have, a handful of deaths in either group, this is a sign that it's probably a very unstable finding and very well may be an a posteriori consideration. Next, please. And we're going to talk through a couple of examples of this from the literature. So one intervention that has, I would say, an apocryphal status is the caring contacts intervention. So the idea is sending notes or text messages or emails to people who've been identified as at risk for suicide, and this is going to reduce their risk of death by suicide. The Motto study, this is considered the grandfather of this area. They reported at 2 years post-randomization a statistically significant difference using a one-tailed test. So if they had used a two-tailed test, it would no longer have been statistically significant. And this entire area of research may, have faltered from that point forward. But what you can see in the data they present, small numbers of deaths in both groups, the effect size attenuates, and it's very possible that what they were reporting was a sort of an extreme event that happened more by chance, so a false positive finding, than because of a true difference there. It's also worth noting that their primary analysis was focused on that 5-year period, and comparing the curves between the two groups over the full period, there was no significant difference. So it was more of an exploratory finding, and thus we have subsequent research trying to validate that, but to date, no study has come up with really good findings for this type of intervention that support that it has a benefit for death. Next, please. The other study we're going to talk about in brief, this is the Fleischman 2008, the World Health Organization Brief Intervention and Contact. So it involves a brief intervention with people who had a suicide attempt and then a contact component after that. So it's a little bit more intensive than the intervention Motto was studying. The published report that they gave showed a huge difference for suicide mortality. So 2 deaths in the intervention group and 18 in the treatment as usual group. Again, small counts, so not the most stable finding, but a lot of folks were very excited because it was statistically significant. A problem, though, is it's only reported from the 5 sites that fully implemented the protocol. So that should raise a red flag for selection bias. And their outcome was defined based on informant reports of both vital status and cause. And the informant, it was lay informants. This was not, talking to medical professionals. So we've got serious concerns of bias from a result like this. Next, please. And so this, from just a purely statistical perspective, raises the specter of just volatility, and that we're finding sort of edge findings that are totally possible to observe, unlikely, but possible to observe by chance alone. But because we have small event counts, we were able to see these extreme events, and because it went in the direction that was desired and it had the right p-value attached to it, it ends up in the literature. So a good thing to ask yourself when evaluating a study purporting to affect suicide mortality: did it have enough events to come away with a reasonable estimate, and is their reported effect size plausible? Based on the HUBIC, this intervention that is not particularly intensive was associated with an 89% reduction in mortality risk. If that were real, and you did just this intervention, you should see an absolute, just absolute reduction at the population level in suicide mortality. And implementing interventions like this within the VA system or within DoD, we don't see anything anywhere near that. So that should have been another one where your antenna come up and say, let's think on this. Next, please. So some workarounds, as we saw, motto using the one-tailed test, that's going to increase, or it decreases some of your sampling burden. Because a big problem with these trials is it's like, okay, so I need 200 suicide deaths in my control group. If I'm going to do this right, well, that's going to require a sample that's in, 50, 100,000. I can't possibly do this. And so we need to think about ways to, change it. You could increase your alpha. You can change the duration of the study. So instead of a 1-year risk of mortality, you follow out to 5 years or even 10 years, but then know that your effect size would probably attenuate. And so you have a longer follow-up time, but you have to detect a smaller effect. And so it ends up canceling out the benefit potentially. Next, please. Others, repeated measures, it doesn't work with death since you only die once. Focusing in on a high-risk population, this is what's commonly done. So if you focus among people who have had a suicide attempt or who have been just released from inpatient psychiatric care, that can certainly do it because it's raising the risk in the base population, but you still are going to need to identify a large enough group to have enough deaths to do a stable analysis. All-cause mortality could be useful. You'll have at least as many deaths from all-cause as you would from suicide. It accounts for competing risks, but it raises the specter of less directness of evidence. You don't have as clear of a data point that it's specific to suicide. Next, please. And then other ideas. So the intermediate, and this is related to what Larry talked about briefly, the proxy outcome. So we have our causal model for treatment, which is now going directly to the intermediate. Even if we did an RCT, we could identify the causal pathway from treatment to the intermediate. But then everything beyond that, the effect of the intermediate on suicide becomes more ethereal, and it rests on even more assumptions than the study linking the treatment to the intermediate. And so it does not bode well for strong evidence of a benefit for suicide, even though it may be an easier study to complete. Next, please. And then suicide attempt. So another focus here, because this is more common than suicide mortality, it could be useful. A quick thought experiment here is 2 different worlds. In world 1, suicide attempts that are non-fatal and suicide attempts that are fatal, these look a lot like each other, and the fatal are just a random subset of the non-fatal. And so any benefit we can demonstrate on suicide attempt is bound to capture a similar fraction of the potential fatal events in there. At the other end of it is world 2, where we believe that fatal events are a non-random subset of non-fatal events. And so when you have evidence that you've reduced non-fatal events, it's entirely possible that none of those events would have become fatal events had there not been the intervention. I suspect reality is somewhere between these 2 possibilities, but it's unclear which one is closer to the reality on the ground. Next, please. And then I am going to skip over these last couple slides because they sort of dovetail right into what Dr. Evatt is going to discuss. And so I am going to pass the baton over to him. Thank you.
All right, I'm just going to take us home here by talking a little bit about maybe a way forward here. I think Larry already touched on some things we can do better with respect to our approach to research, with our respect to identifying the best suicide interventions. But I'm going to focus a little bit on a specific type of research here. If we could go to the next slide, please. All right. Really what I'd like to talk about is the difference between focusing on our entire population and focusing on a targeted population. Not surprisingly, and I think naturally, when a lot of us focus on our specific populations when we're trying to address the issue of suicide. So Derek and I are from the DoD, a lot of other folks here are from the VA. We look back over the last 10 years, over the last 20, 25 years, and we see our rates are increasing. So of course, we want to focus research on our population. How can we reduce rates in our population? But the reality is that this is really a national problem. Suicide rates have been increasing everywhere for the last 20 plus years. And really, maybe with only a couple minor exceptions, that's happening across demographic categories. Moreover, some of the large differences that we think we see in groups when we see increases in suicide, when you actually do adjustments based on things like, the regular things, gender, et cetera, those differences fall away. So here's an example from our population where you can see that in US adults, we see an increase in suicide over the last 10 years or so. The military rate looks much higher when we look at the crude rate, but when we look at an adjusted rate, they're very similar. The increases are very similar. And that's not surprising. The military is very young and it's very male. So everybody here knows that being young and male puts you at increased risk. So not terribly surprising. But really, I want to bring that up to segue into this idea that it isn't really about any of our individual groups, even though that's what's important to us. We really need to focus on the whole population. Next slide, please. And in addition to the fact that this is a national problem, there's actually some weaknesses with targeting specific populations relative to a larger, more broader global approach. First of all, some of our assumptions for targeting specific populations, I think aren't correct. When you look at the large systematic reviews of risk factors for suicide, you find that those socio-demographic and life event factors actually have the smaller predictive values for death by suicide, whereas clinical factors tend to have stronger. So we're kind of separating our groups based off those demographic factors, when in fact the risk is coming from other things. And those stronger risk factors are occurring, not surprisingly, across our entire population. Also, I think Derek just did a wonderful job of demonstrating all of the issues and problems with trying to study a low base rate outcome. The sample size issue is our monster. It's the big issue here, right? And so by targeting our studies, when my team does a systematic review, we look in the literature and we look for suicide intervention studies. We find study after study after study that is, this prevention intervention on this population in this city, right? All you're doing is making your sample smaller and smaller. So that sample size issue becomes even bigger. Additionally, when you have that kind of targeted population, it's more vulnerable to those geographic and environmental factors that could also influence your study. And again, with a low base rate outcome, it's even harder to control for those things. Finally, and I think this is really important, even if you think your group or population or your population of interest is the important one, there's something unique and special there, you'll never find out what that unique special thing is if you just study that population. You have to study a broader population to compare it to other groups. And we just don't do that enough. Next slide, please. Additionally, Larry really went into this, but I just want to talk about it a little more. Our current approaches aren't working. As I mentioned, rates are going up everywhere. This is really a logic puzzle. There's not much to it. Either our current approaches aren't effective, they're targeted insufficiently, or they're only partially mitigating, the increase that's happening because of whatever X factor that we haven't identified. None of those things are great. All of those things mean we need better research. We need either better interventions or better understand how we can target our interventions and use them. Additionally, I also want to point out that when you have this kind of, these kind of smaller studies with lower sample sizes that are on targeted populations, the risk goes both ways. Not only do you increase the risk that you might find something works when it really doesn't, you're actually increasing the risk that you might find that your intervention that actually works really doesn't. So that risk goes both ways. And then finally, again, Derek did a great job of demonstrating, we really need large samples to be able to answer this question well. We can't do that with these targeted studies. We need multi-site studies. Next slide, please. So I would argue one way forward, not the only way. Larry did an excellent job of talking about how we can focus on, the comorbidities of death by suicide, the other elements that are involved in death by suicide. But for the piece on trying to reduce death by suicide, I believe we need large national cross-agency suicide prevention studies. Studies like this, they give you a sample size sufficient to detect changes. and they allow you to do comparisons across subpopulations. But there's very good reasons that we don't do these studies. I'm involved in funding in the DoD for research that we do. We don't do these types of studies because they're super expensive and they take forever to do. We've done many studies like this for things over the years, you guys probably know, in the mental health field. But you can spend 5, 6, 7 years and you only find out about one intervention. You do this massive study, find out about one intervention. You might find out it works, you might find out it doesn't, but at the end of the day, you're not moving things along very rapidly. So, these kinds of studies do solve our problem of the low sample size, but they create all kinds of other problems, that really make research move glacially slow. So we need innovative approaches, right, that allow us to look at a variety of intervention, population, and implementation of comparisons really dynamically while we're conducting the studies. Those types of approaches exist. Next slide, please. So this is an example of one such trial design. It's called an adaptive trial design. It's not the only sort of innovative hybrid type of design that allows you to address some of these issues that you have by trying to run large studies with large numbers of people. Now, as you'll see here, a normal study just has design, conduct, analyze. That's how you run the study. We come up with a priori hypotheses, we design the study, we conduct it, analyze the results, we're done, right? This type of study adds in a new element, which is that while you're conducting the study, and the rules for doing this are a priori, right? We're not breaking any rules and changing things in the middle of the study. But while you're conducting the study, you review the results, and then you can make adaptive changes to the study. So you can actually change things in the treatment arms. You can actually change the way you recruit people. Why is this so important? For those of us who've worked on clinical trials, you might know halfway through the study, you might find out like, people don't like this treatment, or we're really not recruiting well for this treatment. Like, if only we could have changed this one thing before we started this study, we would have done so much better. Well, now you can for this with this type of study design. You can even include lots, again, using those sort of hybrid approaches. You can include multiple interventions. You can switch out interventions mid-studies. There's a lot of things you can do. It's an enormous investment, but you can address some of those things. And next slide, I'll talk a little bit more about some of the advantages and what you can do. So again, you'd want a large study. You want to collaborate because this is a national problem. It's not a problem just in our populations. That allows you to also standardize your methodology. So all of our big data stuff that comes out after the study is all better because we have all this data that we can share and we can all analyze that standardizes methodology and measurement. You can consider multiple interventions. There's roadmaps for how to do this in the literature. You can use adaptations to modify or eliminate your arms as you go along. And it really allows you to more efficiently roll things out. Again, you're not waiting the 6 or 7 years. If you start the study and when you do this thing in real life, people don't like it, you can immediately either change the intervention or try out something new, something that just popped up in the literature. And what I really like about this is it's a health services approach to clinical trials. You can address some of those intervention uptake things, care coordination things that you can't predict when you start a trial, but that happen. Next slide, please. I also did want to briefly, is a little bit of a change of a direction here. We're talking all about our national stuff. We're talking about not having a targeted approach. Part of not having a targeted approach is to take a look around a little bit about what the rest of the world is doing. And I also wanted to point out, this isn't a problem just in the United States. If you go back if you get into the literature and you go back to those early 2000s, from about 2000 to 2010-ish, a lot of countries around the world started having increases in suicide. And I included a couple examples here, but around 2010, a lot of countries started doing some pretty large-scale interventions in their countries. And some of those countries had some good luck. I do conveniently end the sort of discussion around the late 2019, 2010s, 2020, because COVID is such a, impossible thing to understand how it's affecting things yet, I think. But just as kind of as a case example, not that we should do these things, In Japan, they had this massive increase up from like 2000 to 2010. And then they did this large, it was really a socioeconomic intervention. And they had a very large reduction in their country in suicide from 2009 to 2018. Europe generally saw a reduction in suicide from 2011 to 2019. That was a little different with different countries, and they all did different things. But again, great example. There's a lot of literature to look in there. As we try to decide how to tackle things in our country, we definitely shouldn't be ignoring what the rest of the world is doing. And some of them are having good success stories. They have different populations. The things they're doing might not work, but it's worth looking at. I did want to include the slide. I think you could have 4 or 5 slides on this, because when you start digging around at what other countries are doing, it gets really interesting. Next slide. So just final conclusions here. If we're looking at the death by suicide outcome, again, there's a lot of great outcomes you can look at, as Larry pointed out, that are not death by suicide. If we focus on other things, we might get more bang for our buck. But if we're going to look at the death by suicide outcomes, we really do need large trials that give us the sample size necessary to actually detect these differences, because otherwise we're just kind of going in circles when we're never actually getting that strong evidence. National studies is really the way to do it. Suicide's been increasing everywhere. It really, it is validated by that fact. And then adaptive designs or other similar innovative designs allow us to do this sort of study while limiting some of the drawbacks on how long it takes to do them, the limitations on how many interventions you can look at, and the cost and duration of the study. I think that's it. So I turn it over to you guys and or Larry for whatever's next. Thank you very much.
Thanks, Dan and Derek. We will open it up for questions from the audience if anybody has stuff they want to discuss.
You're welcome to just speak up or use the chat, however works best for you. Amanda had a question for Dan in the chat. Just wondering if you could briefly talk about the international interventions. That was interesting.
Yeah, I don't think I can say too much more than I already said. In Japan, it was a socioeconomic intervention. So I think they were identifying, which I think many people would argue is, like neglected in our country, but I think it would be up to the independent. We don't have a lot of research looking at it, but I think they were, their notion was that this was economic, that people were struggling, and they created a program to help people that were struggling. I don't have that many details on the program, but that was the program. I think a lot of people would argue something like that you actually could pay off in spades in our country. But I think when you look at those kinds of socioeconomic interventions, across countries, you also have to consider that the social programs and economic programs across countries are also much different, especially in the United States. So implementing something like that, you have to take those things into consideration too. Across Europe, there were different interventions. I did try to get a handle on it. I spent some time in that literature. There's different interventions across all of those different studies. It's kind of impossible to summarize them, here in a minute or two, but they did not do the same thing across all of Europe. Europe, during that time period, Europe was also sort of going through its, what it's gone through with, becoming more collated Europe. But back then, they were doing their own things, and I think there are some lessons learned from those different things.
I think one thought that I had is this is really highlighting that the problem that there's also this way that we're trying to solve a problem that's being created at a societal level, and that when you look at the US numbers compared to other numbers internationally, which I did recently and was like, right, like we are really starting to be an outlier. So I think you're talking about some specific examples with Japan and Europe, but I think that the fact that we're continuing to go in a negative direction when other places are going in a different direction, I think is an important thing for the United States to consider, and perhaps justification for more national level research is that as a country, something is definitely happening that's not happening everywhere. We can't assume this is just a global issue.
Yeah, I think that's exactly right. And I'm sorry, Larry, just real quick. And yeah, that was one of the whole points was that, but from 2000 to 2010, they were looking like us. Everybody was going up together at that, at that low increase. And then we sort of started to separate from the pack.
And I think just to add to that, you're absolutely right, Kate. And both in terms of us conceptualizing the problem, we tend to stick to those national boundaries, but also in how we address the outcome, right? And so I always think back, like, what if this were a medical issue? What if it were heart disease or cancer? How is the research done on those levels? It's not defined by, the border of your country or community. These are international things. And so that really is, I think it beckons that pull to study this on a much broader scale than just keeping within, the DoD or the VA or the U.S. health system or whatever it might be.
Question, Kate. Great presentation, guys. I help support the pilot study program for early investigators in SCRC. And the type of research you're proposing is kind of out of scope for pilot studies and early investigators. And I'm wondering what you recommend for the folks at that stage in their career.
So I'll jump in first, I guess. Yeah, it's tough because, what we're advocating here is really a much larger trial design. And so I think if we had, sort of the national support for these large scale cross site trials, one example that we often sort of dream about would be, what if every VA medical center had a suicide prevention clinical trial site that were all part of this larger, study group? Would there be opportunities for those young investigators at those sites to run and manage those specific arms of the trial, doing, as Dan mentioned, sort of the adaptive sort of designs where they could really highlight, okay, what if this change was made, or what if we switch this component or this intervention? And so it would really be sort of taking those key parts of a much larger system and kind of having some ownership in that.
So one other possibility I would add is that so a lot of the biological research is showing, and the neurobiological research is showing that there's some commonalities and risk taking and risky behaviors in general. And so I think I think we see, so for, as a little advertisement, I'm the chair of the CDMRP research portfolio. So we get a lot of smaller studies looking at suicide. And I'm always thinking, why not just look at risky behaviors? Like, you don't have to have death by suicide as your primary outcome in a study with 50 people or 100 people. You could look at risky behaviors, or I think Larry's list of sort of related outcomes was, in his slide are perfect. Look at those outcomes. Suicide can sort of, to me, at that level, you're only really including suicide for like hypothesis building for further studies. You want to look at these other outcomes that are related to suicide, also extremely important outcomes. And then, like I said, neurobiologically might be related to some of the same sort of, disinhibitory processes that are putting people at risk for suicide anyway.
I'm gonna have the last word and just really emphasize the idea of our younger generation really learning adaptive designs, learning optimization models. I think that is really knowing and understanding how those models work. I think is going to be really critical if we're going to get these large studies to happen. And I think there'll be arms in there for people. I do want to say thank you to all three of you for presenting. This was really helpful. I think it puts in context a lot of the work that we do inside the healthcare system, where, to me, I don't think that's necessarily going to move the needle you're trying to move, even if we had perfect interventions, because of course so many people don't choose to come to us in healthcare. I don't think that's going to get any better anytime soon. But I think it's really, really critical to kind of get out of that world for a moment and kind of recognize that there's a whole other area of suicide research we need to be thinking about if we're really going to move the death by suicide needle. So thank you again so much, and we'll see folks again next month, hopefully. And please, I put in the chat the links to our MailChimps. I hope you'll sign up for that so you hear about our future presentations. And thank you all so much.